Hello, my name is Dr. Frank Guido-Sanz, and I will be presenting the Gastrointestinal Healthcare Problems Lecture Compendium. Um, Today, we're going to examine the GI mucosal injuries, specifically the lower gastrointestinal bleed. This is actually the second lecture in the series of gastrointestinal mucosal injuries. We have previously covered upper gastrointestinal bleed, and now we're going to be covering lower gastrointestinal bleed. So let's take a look really quick at the lower gastrointestinal tract. Remember, what separates for clinical purposes in determining the etiology of intestinal bleed is the ligament of Treitz. Anything above that is upper gastrointestinal, and anything below that ligament is lower gastrointestinal tract. It usually covers the lower gastrointestinal tract, the gallbladder, the liver, transverse colon, ascending colon, lesser omentum, stomach, duodenum, descending colon, and sigmoid colon. This is a lesser omentum, anterior view of liver and gallbladder lifted. uh, a summary of an approach to ICU patients with lower gastrointestinal bleed. Um, Basically, we're going to immediately assess and stabilize the patient's hemodynamic status, the ABCs of resuscitation, airway, breathing, circulation, right? Then we're going to determine the presence of lower gastrointestinal bleeding by history, by physical examination, and sometimes by nasogastric aspiration. We're going to arrange appropriate diagnostic and therapeutic interventions to stop any active bleeding. And finally, we're going to treat any underlying lesions and monitor and manage the comorbid illness. Essential diagnostic tests and procedures are necessary for the determination of lower gastrointestinal bleed. History taking, including previous operative interventions and medication, is crucial. Physical examination, including digital examination, remember what we talk about? Rectal exam is also essential. Stools for guaiac for anemic patients with suspicious GI blood loss is necessary. Also, we need a complete blood count to determine the level of anemia. Endoscopic procedures like sigmoidoscopy, colonoscopy, enteroscopy, and capsule endoscopy. Barium studies, bedside ultrasounds, radiologic procedures like angiography, nuclear scintigraphy like using technetium labeled red blood cell scan, and other examinations for affected organs due to unstable hemodynamics, such as the electrocardiogram in the presence of acute myocardial infarction. Really quick, for capsule endoscopy, thousands of still images are captured by a tiny camera during capsule endoscopy. It's an incredible technology. Strung together, they create a video that are used to look for abnormalities in the small intestine, such as bleeding, like it's the one shown in this image. Pretty neat, right? Very accurate, very and very low invasiveness. So when we talk about treatment, we have to make sure that we preserve the hemodynamic status. So ensuring stable hemodynamic status using fluid and transfusion of blood components is essential. Endoscopic therapies include local injection, electrocoagulation, hemoclipping, argon plasma coagulation, and elastic banding according to the nature of the bleeding. Radiologic interventions include angiography with intra-arterial vasopressin infusion, embolization, and glue. The adverse event caused by treatment modalities such as perforation caused by endoscopic thermocoagulation or bowel infarction due to angiographic embolization should be monitored and managed. And surgical consultation is warranted for severe lower gastrointestinal bleed in which the patient cannot be resuscitated or if all available therapeutic modalities failed previously. So, a quick overview. Let's take a look at the cause of admission or major comorbid. Um, it's a consequence, main consequence is anemia and hypovolemia. How we define this lowered gastrointestinal bleed again is by definition in relationship to the ligament of Treitz. Anything distal to the ligament of Treitz, including small bowel and colon, that constitute the origin for low gastrointestinal bleed. It's also LGI comprises of 20 to 24% of all major GI bleeding reported in the literature. LGIB is distinct from UGIB, obviously because of the location, also because it's not as common, has lower mortality, but is higher in those who begin bleeding after admission. Death occurred due to underlying disorder or nosocomial complication. Bleeding can originate from any part of the lower GI tract, and the blood loss is often intermittent in nature and it's difficult to identify the source in the absence of active bleeding, especially angiographically, because we have to capture the moment where that vessel is bleeding. The colon preparation before urgent colonoscopy is obviously needed, but is often incomplete. Recurrent bleeding due to angiodysplasia or diverticula is common, and unlike upper GI bleed, there are no evidence-based and effective pharmacologic therapy for lower GI bleeds. So, what are the demographics? We see this in younger than 40 years old patients with small bowel tumors like lymphomas, carcinoid tumors, adenocarcinomas. We also see anatomic anomalies like the Meckel diverticulum or the Dieulafoy lesions. Genetic problems associated with lower GI bleeds includes polyps from hereditary polyposis syndrome and Crohn's disease and ulcerative colitis. In patients that are older than 40, we'll see this from bleeding, from vascular lesions, and mostly neoplasms. The presentation, as I said, it could be very insidious. In patients that are immunosuppressed, the cause is often associated with CMVs, cytomegalovirus ulcers. We see also renal failure and aortic valvular stenosis, which increases the risk for angiodysplasia. We have patients also with history of radiation therapy for cervical prostate malignance, producing radiation colitis, making that tissue very friable and brittle and prone to bleed. Most bleeding sites are in the right colon, and 2 to 25% of patients with presumed LGIB will also have upper gastrointestinal bleed instead. So what are the causes? In the small bowel, vascular ectasia is one of the main causes. Ectasia means pathological dilation of a vessel from ectasis. Focal active bleeding, small bowel in the small bowel tumor associated with either lymphoma, adenocarcinoma, the GIST tumor, or other tumors. Also, NSAID-induced enteropathy, Crohn's disease, Meckel diverticulum, vasculitis, like in systemic lupus erythematosus, Behçet's disease, Schlein-Henoch purpura, infection related to ulcers like CMV and so forth, small bowel varices, and aortoenteric fistula. If the cause is chronic, we see again vascular ectasia, diverticulosis, ischemic colitis, acute hemorrhagic rectal ulcer syndrome, neoplasia, post-polypectomy, inflammatory bowel disease, infectious colitis and ulcer, NSAID-induced colopathy, radiation colitis, hemorrhoids, Dieulafoy lesions, colon varices, and aortoenteric fistula. So we have talked about this Dieulafoy lesion. What is that? This picture shows a mesenteric angiogram of the case patient revealing two pseudoaneurysms on the jejunal branch of the superior mesenteric artery. That's your PSA. The PSA is your pseudoaneurysm. Dolichoid lesions are large, tortuous arteriole in the stomach wall that erodes and bleeds. It has been recently identified also in lower GI bleed, specifically in the jejunum, the right column, and in the rectum. Other clinical presentations, occult fecal blood as positive. We see also iron deficiency anemia and melena, intermittent scan hematochezia, acute massive overbleeding sometimes, and hemodynamic compromises like pallor, fatigue, chest pain, palpitation, dyspnea, tachypnea, orthostasis, dizziness, syncope. Um, all these presentations demand an aggressive treatment approach, and the compensatory mechanisms delay onset of actual hypotension. So don't be fooled. Don't wait until the patient is showing overt signs and symptoms of hypotension, because then the possibility of larger lower gastrointestinal bleed may occur. So let's take a look at the anatomy and low gastrointestinal bleed. Again, the ligament, to make a determination of LGIB, the bleeding has to occur below the ligament of Treitz, all the way down to the anus. Small bowel is actually very affected, specifically the jejunum and the ileocecal valve, ileum-ileocecal valve. In the colon, we see it in ascending, transverse, descending, sigmoid, rectum, and it also includes the anus. So, what are the tests that we have available to evaluate that LGIB? So, most common form of GI bleeding is to test for fecal occult blood. Is the most common first investigative step in the ICU. A guaiac-based test detects products of degradation of heme and is better for detecting bleeding in lower GI, where the blood is not degraded yet. We also have the immunochemical fecal occult blood tests that have high sensitivity and specificity, but is very limited because of the need of intensive lab processing, and not every institution have the capabilities to do immunochemical fecal occult blood test. And we also have a heme porphyrin test, which is accurate and is the most sensitive method for upper or lower GI, but not the most specific. As far as invasive evaluation, NG2 placement, the blood should not reach or pulse across the ligament of Treitz. But remembering that 2 to 25% of patients with acute severe hematochezia also have upper GI source, we can never discard lower gastrointestinal bleed if we have positive NG blood presence. Place if source is not identified by colonoscopy is the guideline from Society of GI Endoscopy recommendation to do that. Also to place if hemodynamic compromise and hematochezia are present. The absence of blood in NG aspirate is not sufficient to exclude upper GI bleed, though. So we can see also bile without blood. If we see bile without blood, it's sort of like reassuring that we don't have an upper GI bleed. But again, we have to take those findings very carefully. Sigmoidoscopy is the gold standard for lowered GI bleed diagnosis. We can do a sigmoidoscopy, a whole colonoscopy. We can also use capsule endoscopy, or the push enteroscopy, or the double balloon enteroscopy. Actually, I have never seen the two last ones, the push enteroscopy and double balloon enteroscopy. I think those are very GI specific and specialized procedures, not very commonly seen, at least in the setting of ICU patients. So, diagnostic and treatment. Endoscopic local hemostasis can be obtained the same way we do it in the upper GI tract. Mesenteric visualization is difficult, so arteriography sometimes is necessary for embolization and also the delivery of pharmacotherapy. So, all this is done under interventional radiology using radionuclide scintigraphy. Advances in endoscopy and radiology have decreased the rates of rebleeding and surgical intervention. And also, the use of transabdominal ultrasound is a good diagnostic tool in GI emergency. This is the FAST. If we see blood under ultrasound, especially in the Morrison pouch, we can suspect GI bleed, and in the event of that, surgical consult should be placed immediately. As I initially said, there's limited pharmacologic treatments for lowered gastrointestinal bleed. Angiodysplasia is usually corrected with estrogen and the administration of octreotide. And also the intractable bleeding from radiation with topical formalin. But again, these are not very effective pharmacological treatments for lower gastrointestinal bleed. Organ plasma coagulation of angiodysplasia in the colon is also used with certain effectiveness. Argon is like a gas, and the insufflation of that gas in the area produce coagulation of the angiodysplasia. So this is a decision tree. In general is an approach to lower gastrointestinal bleeding. As you can see, once you have the suspicious of lower GI bleeding, you can check for occult bleeding, or if it's something that is overt and acute hematochezia. Regardless, the two presentations, the first question we're going to ask is this patient stable? If the patient is stable, vital signs are stable with occult bleeding usually, so we just monitor the patient. If the patient is not stable, we go through the primary survey, airway, breathing, circulation. We secure airway, we administer oxygen, we place large IV catheters and CVP line if possible, and administer fluid and blood components. We monitor blood pressure, EKG, and oxygen saturation. And we also use routine electrocardiogram for age patients with history of CAD, monitoring of hemoglobin, PT-PTT, coagulation factors, correct if there's any abnormal, discontinue any harmful medications, and keep the fluid resuscitation until we gain hemodynamical stability. Here, this is a general approach to lowered GI bleeding. Again, basically, for acute severe hematochezia, we take in consideration history, physical exam, and resuscitation measures. And then we question whether this is also an upper gastrointestinal source involved. If no, we go straight to a colonoscopy to identify the source and treat. But if the source is not identified, we perform an adequate exam. And in this, that still pointing to active bleeding, we take the patient to interventional radiology for angiography, plus minus treatment, or plus or minus surgery. If the source is not identified and there's an inadequate exam, also we go straight to angiography. So basically, the terminal decision here is destination intervention is angiography. If the upper gastrointestinal source is ruled in, Then we do EGD and we treat. Um, Also, enteroscopy and video capsule endoscopy are available choices for identifying sources of bleeding. So, determination of bleeding site history is extremely important. What are the stool characteristics? The color, the duration, the frequency. Is there any motility issues involved with this bleeding? If there's fever, pain, do we have significant medical or surgical history? Medications, what medications the patient is taking that can, be provoking this lower gastrointestinal bleed. Bloody stools, blood in and GI transit time is essential to be recognized. Anything less than 5 hours transit, the blood will show in stools red color. Anything above 20 hours, the GI transit time is usually greater than 20 hours, 24 hours. You will see melanic stools. Melena can be from upper GI, from small bowel, or from slow oozing from the right colon. Hematochezia is usually more associated with left colonic and rectal bleed. If blood is coating the surface of the stool, it's usually the origin from the left colon, the rectum, and the anus. If blood is dripping into toilet, we are suspecting hemorrhoidal bleeding. And if the stool is mixed with blood, it's usually coming from the right colon. So knowing these descriptors will also show us or point us to the origin and probable source of that GI bleed within the gastrointestinal um, system. And that little table there um, sort of like summarize the probability of upper versus lower gastrointestinal bleed source. Severe constipation is another issue that we need to be considering in the history. Colon cancer and colon ulcer are usually associated with lower GI bleed. The ulcer of colon is due to pressure irritation from prolonged constipation. That's what is called a stercoral ulcer from stercal. Diarrhea, and enterocolitis. If the patient has fever or pain, we can suspect inflammation-related bleeding, like infectious colitis or inflammatory bowel disease. If there are a history of colonic polyps, diverticulosis, or colonic tumor, that is also extremely important to know because these entities are very prone to lower GI bleed. If the patient had a recent colonoscopy with polypectomy, we need to know that. If there's a history of aortoiliac reconstructive surgery, that is important because colonic ischemia occurs in 1 to 7% of patients going under this procedure. If medications are also a biggie here, medications that may damage the GI mucosa, like NSAIDs, like biphosphonate, that's like also potassium chloride and some anticoagulants, and also a history of SSRIs intake. And on top of all this, family history of colorectal neoplasm put at risk individuals for lower GI bleed incidence. So, our physical exam is going to be concentrating on identifying signs and symptoms of blood volume depletion or hypovolemia. Um, we're going to concentrate also on examining the bleeding source, determining comorbid conditions, taking good vital signs, listening to heart and lungs and concentrate on those two. And the abdomen, whether the patient has tenderness, because that will be indicative of inflammatory processes. Pale conjunctiva, which points out to anemia, which can be also. Remember, we said there is an insidious form of lower GI bleed that occurs with certain chronicity. Rectal exam for anorectal lesions confirms stool color. And again, the conjunctiva for anemia. Lab, like that that little image depicts, it takes all types. Um, it's imperative that we do a CBC with BUN and creatinine, coagulation profiles to run some liver tests, specifically if we are suspecting some cirrhotic involvement of the liver. Very essential is blood type and cross match, because we are going to be providing replacement for blood products and electrolytes. So basically, this slide shows a decision 3 for overt acute hematochezia. Basically, again, we have like described before, and the end goal is to determine whether this patient can be treated with minimal invasive procedure with and how many studies are going to be necessary to make a conclusive determination of the etiology of that low gastrointestinal bleed, especially in the presence of instability with the patient. Um, so the approach for this hemodynamically stable lower gastrointestinal bleed also differs. Let me go back. I'm sorry. Also differs a little bit from the approach for unstable lower gastrointestinal bleed. But again, in essence, is just determining the appropriateness of the um, uh, diagnostic testing and the relevant treatment to address the etiology of the lower gastrointestinal bleed. Colonoscopy is a procedure of choice to make a determination of the bleeding site. Um, Enteroscopy is done for proximal small bowel bleeding. Um, and so far, bedside colonoscopy in critically ill patients appears to be safe, and again is a procedure of choice uh, to determining the bleeding site. Um, Colonoscopy prep in the critically ill is kind of like a challenge for practitioners and a challenge for patients and a challenge for nursing personnel. Safety is also always an issue because there's some problems with type of preps like fluid overload or electrolyte imbalance, like especially when you're using phosphate-based solutions or saline-based solution. It's difficult to provide feces-free colon, so we have to take what we got, basically. There's different methods. We have the perol gut lavage with saline or balanced electrolyte solutions, which is very rapid and effective, but may not be tolerated in like a percentage of as high as 11% of the patient population. Um, Major methods like isosmotic solutions or hyperosmotic or stimulant laxatives are also used. Polyethylene glycol electrolyte lavage is also very common. It's isotonic, non-absorbable electrolyte solution that yields no significant fluid electrolyte shift. So for patients that are like with congestive heart failure or have some metabolic derangements or some renal impairment, this is a good choice. and is very, very good for rapid purge. Colonoscopy is the first choice um, of for cold blood or stable lowered gastrointestinal bleed. Is inadequate for ongoing severe hematochezia. It yields higher diagnostic yield and lower complication rate than angiography. Um, Most amenable to colonoscopic treatment are the angiodysplasia and the diverticulosis. And we can use some coagulation methods like the injection therapy of ethanol, epinephrine, or saline, a heater probe, a monopolar or multipolar electrocoagulation, the argon plasma coagulation, hemoclips, and even band ligation. Hemiclips, there's like a surgery and endoscopy stay with patient generally. You see there in the left corner of the slide a gastric mass with deep ulceration, and that's the before and the after, where hemostasis is achieved with the hemiclips. And you see the probe there deploying the clips are like staples. They're basically a mechanical obstruction of the gastric mass, or if it's a bleeding polyp, or a protruding varicose vessel. Uh, ASG guidelines, the American Society of Gastroenterology, recommends colonoscopy effective for diagnosis and treatment. Colonoscopy is recommended in early evaluation, and thermal contact modalities and epinephrine injection. They have determined that it's useful in the treatment of bleeding diverticula, vascular ectasia, or in post polypectomy bleeding. I want to say something about the ruptured diverticula. Ruptured diverticula or bleeding diverticula is the second most common cause of low gastrointestinal bleed in older age, in patients that are on NSAIDs, um, also resulting in hematochezia and in painless abdominal bleeding. So this is very helpful to remember that. Enteroscopic and capsule endoscopy. The small bowel presents a challenge for evaluation. It's very difficult to evaluate small bowel because of the long length, the looping, the free intraperitoneal location, the active contractility, and all these factors limits the standard endoscopy. Because of 10 to 25% of LGIB originates in small bowel, this creates a diagnostic dilemma. But we have current tools like a push type enteroscopy or PE, the double balloon enteroscopy, the intraoperative enteroscopy, which is like they basically do a laparoscopy and they create like a little window on the small bowel, and then they sort of like do an enteroscopy, and then they have to suture that. But actually you can imagine the risk for surgical complication. But the safest one, and is very commonly used, is the capsule endoscopy. Capsule endoscopy was developed by Paul Swain and Gabriel Idan in 2001, and is mainly used for small intestine diagnostics. In essence, wireless imaging is an ingestible capsule endoscope that records data. And so you are from a workstation evaluating the transit of this capsule. It's very small, with a very small weight, and it captures 2 images per second. And that little battery that propels that ingestible endoscope last can last from 6 to 8 hours, and all that data is transmitted to an external data recorder. Um, the picture there that you have basically summarizes what capsule endoscopy is all about. Again, the advantages are painless, no sedation needed. The provision of 3D colored images of small intestine without surgery, and allows doctors also to make early accurate diagnosis of problems so they can recommend the most appropriate treatment. So, pretty incredible technology. The disadvantages is because we can't get biopsy specimens, because there's no therapeutic interventions, and because the localization of some lesions is imprecise because of the nature of the small intestine. Very loopy, very loose, with very high peristalsis. Again, the advantages are low risk. Um, the major risk of this capsule endoscopy is entrapment in the GI tract, but it's usually very well tolerated. Its use in critically ill patient um, has been limited. Um, for example, intubated patients cannot swallow, so we can deploy the pill. Um, or in patients that have bowel transit delays. Other non-endoscopic methods, one of them is with radionuclide scanning. Radionuclide scanning uses red cells labeled with this technetium, radioactive technetium, and detects bleeding at a very low rate. You recall from the upper GI bleed lecture that they're used for low rate bleeding, less than 0.5 milliliters. So it can capture zero point 0.1 to zero point 0.5 milliliter per minute bleeding. It's a very sensitive tool as well for LGIB. It can be performed repeatedly. It's used as a screening tool, and it can also be used as a following angiography and small bowel enteroscopy or surgery. Here, this is the picture of a 69-year-old male who presents to the emergency room with bright red blood per rectum, and a GI bleeding scan was performed. Early in the study, a focus of increased activity appears in the left lower quadrant of the abdomen. Activity then progressed in a curvilinear fashion, approximating the course of the sigmoid colon. Shortly thereafter, blood in their bedpan did demonstrate the presence of radioactivity. Active gastrointestinal bleeding in the sigmoid colon. GI bleeding scans can detect bleeds again from zero point 0.5 to 2 milliliters per minute, about 10 times more sensitive than angiography. The bleeding scan is then initial imaging study of choice for lower GI bleeds. Okay, so here we have red cells, red blood cells are a label. Um, with the radio labeling agent in vitro and reinfused into the patient. And these images are then acquired sequentially at 1 minute intervals in the anterior projection. So you see the transit of the contrast all over the vasculature of the lower gastrointestinal system. Again, they are very sensitive. They can detect very small bleeds, um, 10 times more sensitive than angiography. And the bleeding scan is the initial imaging study of choice for lowered GI bleeds. Angiography images entire mesenteric system, also can pinpoint localized sites of hemorrhage. It's done through transcatheter interventions. Requires bleeding rates of higher, 0.5 to zero point 0.1 to be sensitive to bleeding. And it's usually done with hemodynamic and stable patients. It's sometimes done after a radionuclide scan. So if that radionuclide scan is negative, probably you won't have a positive angiogram, again, because of the sensitivity of the radionuclide scan. Angiography localized bleeding site in 40 to 80% of the times, but it has complications. You have bleeding at the catheter site, access site thrombosis, contrast reaction, injury to target vessels, even renal failure due to the contrast. And most common injuries are to the superior mesenteric artery, to the inferior mesenteric artery, and the celiac artery. So it's not a very benign intervention. It requires, really highly trained interventional radiologies to perform this. Some of the therapeutics associated with the angiographic method are the pharmacologic vasoconstriction, which is intraarterial vasopressin infusion, selective embolization, deploying microcoils, or polyvinyl alcohol sponge particles that act as, a vesicant, or gelatin sponge particles to create little clots. However, there's a high chance, from 10 to 20%, of intestinal infarction with this angiographic therapeutics. Other imaging includes CT scan that may potentially detect bleeding at 0.5 milliliters per minute or less in 72 to 79% of the cases. MRI plays absolutely no role in imaging lower gastrointestinal bleeds. And ultrasound is very convenient and non-invasive, and obviously non-radiating emitting procedure is easily available, but has very limited use for lower gastrointestinal bleed. In terms of pharmacotherapy, we talk about this, is very limited. Um, the use of pharmacology interventions for the treatment of LGIB, and for endoscopic procedures, is usually the major modality for treatment of LGIB because of the ability to reach lesions. Surgery is left for complicated cases or non responsive to other treatment interventions, and remains the choice for 10 to 25% of patients. So surgery is really treatment of choice if the bleeding source is clearly identified and cannot be addressed by other modalities of treatment. So, how we assess the severity of low gastrointestinal bleed? Well, LGIB ceases spontaneously in 80 to 85% of the time. It does have a mortality rate of like 12%. And one uh, sort of like a stumbling block here for the assessment of the severity of LGIB has been that scoring system has not yet developed to be effective predictors. Some factors predictive of adverse outcome so far identify are comorbidities, the presence of comorbidities, the evidence of acute hemodynamic instability, and the endoscopic presence of stigmata of hemorrhage. Um, Initial hemoglobin may be an accurate marker of severity of GI bleed because it could be absolutely related to baseline, like for example, in elderly patients that are usually anemic by nature, and on top of that, if they have a LGIB, which are sometimes very insidious, is a very poor marker for the severity of the GI bleed. Um, some risk factors associated with obscure LGIB, again, like I was saying, elderly patients or renal patients, obviously because their erythropoiesis is affected. Patients with aortic valvular stenosis, connective tissue disease, von Willebrand disease, in surgical patients, in patients on NSAIDs drugs, immunocompromised patients, and also history of radiation to pelvis. So, for example, elderly patients are at very high risk for vascular lesions. Surgical patients are higher risk for anastomotic bleeding or aortoenteric fistula. Um, the NSAID drug users they have increased risk of small bowel ulcerations, and immunocompromised patients they have cytomegalovirus ulcers, CMV ulcers, and also patients that undergo radiation to pelvic organs. They usually develop radiation colitis. So all these are contributing factors to obscure the diagnosis of LGIB. So how we approach this obscure bleeding? Once we have suspicions of occult lower GI bleeding with stable hemodynamics, first step we need to do is correct the anemia, and then sort of like determine if colonoscopy is appropriate. If we have a negative colonoscopy, we can go for a capsule endoscopy or RBC scan. Um, or if the colonoscopy is positive, then we have to address the treatment of individual lesions. Once and the patients are like that have negative colonoscopy and we resort to capsule endoscopy and RBC scan, if that intervention is negative, then we can do ultrasounds, we can order helical CT scan. But if that is positive, we need to concentrate on a physical exam for proximal jejunal lesions, and look for inconclusive studies or deep small bowel lesions, and ultimately the treatment of those individual lesions if they are identified. Um, if the ultrasound or helical CT is use to further study this obscure bleeding. Depending on the result, whether positive or negative, it will be our intervention. If it's positive, we may repeat studies according to the findings, and if it's still negative, we can continue observation and conservative treatment of the patients. Notice the asterisk on positive intervention for positive capsule endoscopy RBC scan is the use of vasopressin intra angiographic vasopressin or embolization. So, in a nutshell, and summarizing this, LGBI, and the relationship of LGIB with acute myocardial infarction. Remember when we said one of the risk factors was previous, cardiac issues like cerebrovascular accidents and acute myocardial infarction. Well, the LGIB can result from medications or interventions for MI. MI as a result of hemodynamic instability and anemia is precursor, it can be associated with LGIB. A QMI with significant upper or lower GI bleed has a prevalence of GI ranges between 1 and 14%. And we see this in ICU patients as high as 30 to 49% with a 5 to 10% mortality. So you have a patient with low GI bleed and a positive history of acute myocardial infarction. Be very thorough in the examination and in the diagnostics of LGIB. Um, Other LGIB individual causes, one is angiodysplasia. As we said, ectatic dilated submucosal veins. Ectatic means like pathological dilation or distension. And this is the most common vascular anomaly of the GI tract. Um, is due to the generation of submucosal venules, and in the elderly, this is the most common cause of recurrent LGIB. It can be the location pointed to up to 54% in the right colon, specifically in the cecum and ascending colon, followed by the sigmoid colon and rectum for 18 and 14% on both. So the presentation for these LGIB and due to angiodysplasia is bleeding, obviously with what is usually brisk, painless, and intermittent. So when you see a patient, an elderly patient, uh, with taking NSAIDs and a painless um, bleed. Um, Again, you can suspect a ruptured diverticula, which is a very common cause in LGIB in older age, um, but it can also be associated with angiodysplasia. The treatment is embolization or infusion of vasopressin, and if the bleeding is diffuse, hormonal therapy with estrogen, progesterone, and octreotide analogs is indicated. The hormonal therapy is thought to improve coagulation and by altering the microvascular circulation and improving the endothelial integrity. But you have some adverse effects that include breast tenderness and vaginal bleeding in women, and gynecomastia and loss of libido in men, fluid retention, and even stroke. Um, Colonic diverticular bleeding. This is, if we're isolating individual causes for LGIB bleed, the source is a rupture of an intramural branch of marginal artery at the dome of the diverticulum or at the antimesenteric margin. This is in red, guys, for a reason. The most common cause to um, cause of low gastrointestinal bleed. Okay, ruptured diverticular is the second most common cause of LGIB and is usually in older patients with history of NSAID regimen. They present with hematochezia, painless abdomen, painless hematochezia, acute presentation, and it requires immediate emergent intervention in 25% of the cases. You need to remember that. Another individual cause is ischemic colitis. It can result from sudden, often temporary reduction in mesenteric blood flow. It has been increasingly recognized as a cause of acute LGIB with an incidence of 1 to 19% of LGIB. It may be transient and reversible, and the causes are related to low flow states, um, occlusion of small rather than large vessels, and the common areas are the splenic flexure, descending colon, sigmoid colon. The presentation is sudden onset of mild left lower quadrant, crampy abdominal pain with infrequent hemodynamic alterations, bright red blood per rectum, or bloody diarrhea. Associated conditions to this ischemic colitis, you have cardiovascular insult, aortic bypass, aneurysmal rupture, vasculitis, inherit or acquired hypercoagulable states like pregnancy or contraceptives, intense exercise, or the use of drugs that reduce colonic motility or blood flow like catecholamines. LGIB, individual causes specifically related to NSAID induced enteropathy and colonopathy. The cause is usually exacerbation of the inflammatory bowel disease, causing colitis and complicating diverticular disease, which puts the patient at an increased risk of perforation and severe hematochezia. They're usually located in the terminal ileum and cecum, so these areas are particularly susceptible. And the treatment is obviously discontinuation of the drug regimen. You have to recheck these patients in 6 to 8 weeks for resolution, and surgery is rarely needed. Um, so take in consideration all these individual causes of low gastrointestinal bleed. I want to also remind you that um, systemic lupus erythematous vasculitis is also a cause of gastrointestinal bleed. And this you will see in black, presenting with black stools, and it's usually the source duodenal bleed. So it originates in the small bowel. So this is also related to connective tissue disorders or autoimmune diseases. So don't rule out um, lower gastrointestinal um, tract bleeds in patients, and be very cognizant of these possibilities and thorough in your assessment and history taken. And that concludes our GI mucosal injury series and this lower gastrointestinal tract bleed lecture. I hope you enjoy it. This is again part of the gastrointestinal healthcare problems lectures compendium developed by Dr. Christopher Blackwell, Associate Professor and Program Director of the Adult Gerontology Acute Care Nurse Practitioner Program. Thank you very much for your attention.